Morning, everyone. Welcome. Please feel free to share in the chat who you are and where you're zooming in from this morning, and we'll get started in just a moment. Okay, we're going to kick off, and I know that it's early on a Friday morning. I suspect people will continue to file in. Welcome to this fifth conversation in our New Horizons speaker series of the Department of Family and Community Medicine at U of T. Before I welcome our guests for this morning in a new format that we're going to give a try to today, I want to just say a little bit about the series and about this beautiful work of art that you see on the screen here. Next slide, please, Brian. This image on the screen is a wonderful work of art from a Canadian artist named Meryl McMaster, which helped to inspire this series. The series is really about looking up and out at disciplines beyond our own of academic family medicine and thinking about art and politics and all of the broad range of disciplines that can help to inform our thinking. And Meryl McMaster, for those who haven't had a chance to get to know her work, is an extraordinary artist who has a show on right now at the McMichael Gallery in the Hamilton area. And I would really encourage you to spend a Sunday and go out to see it. She's a really inspiring artist. She's a Canadian artist with Plains Cree, British, and Dutch ancestry. And this piece is called Lead Me to Places I Could Never Find on My Own. And it's part of a series called As Immense as the Sky. And just to say how she describes this piece, which is really about navigation by the stars. She says, stories of the constellations have been passed down over generations with both Indigenous and non-Indigenous cultures. Humans and animals have used the stars to navigate for thousands of years and still do to this day. As the stars become hidden by light pollution, we start to lose our way. So this image was taken at the Badlands in Grasslands National Park, which is a dark sky preserve and a preservation area for one of the largest tracts of natural grassland in North America. Perched atop her hat are the indigo bunting birds who use the stars to navigate. Carrying the universe, they lead me to the stars as I seek answers in the sky. So I found that just an incredibly poetic description and such a beautiful image to orient ourselves to this notion of an interdisciplinary speaker series. And I hope that we can draw on many traditions of navigation as we chart our own way as a department and as a discipline. So by way of land acknowledgement and of acknowledgement of the tremendous contributions of our Indigenous colleagues to all parts of life, I think it's a fitting way to begin our series this morning. And so now I'm delighted to introduce our two guests. This morning, I'd like to think of as a friendly conversation. I'm not going to use the word debate because it's not nearly that formal, but one of the great things about being in a university environment is the opportunity for collegial disagreement and debate about topics that matter to all of us. And so this morning, having seen these two learned colleagues disagreeing at times pointedly on social media about the future of virtual care and technology-enabled care, we felt it would be a great thing to bring them together, two faculty members of the DFCM who want to see the health system made better and who have different perspectives on how virtual care is or isn't contributing to that, or which models of virtual care could contribute to that and which ones might undermine it. And so I'm delighted to introduce our two guests this morning, both DFCM faculty members. Dr. Bill Cherniak is an emergency physician with training in family medicine and global public health. Bill serves as the CEO and co-founder of Rocket Doctor, a telemedicine company that allows patients to see a doctor online. He's also a co-founder and board chair of Bridge to Health Medical and Dental, and co-founder, board chair, and CEO of Bridge to Health USA. He's also a founding director of the African Film Festival. Bill has had research published in the New England Journal of Medicine, The Lancet, Academic Medicine, PLOS One, and given numerous speeches in Europe and North America on global health and development. And thank you, Bill, for joining us. And a special thank you to Bill for joining us from Vancouver, which means it is 5:07 in the morning for him. And we're grateful that he was willing to get up so early to join. Dr. Tara Kiran is a family physician, scientist, and the Fidani Chair in Improvement and Innovation here at the University of Toronto. And of course, she's also the Vice Chair of Quality and Innovation here in our Department of Family and Community Medicine. She practices family medicine at the St. Mike's Hospital Academic Family Health Team. Dr. Kiran investigates how changes in the healthcare system impact the most vulnerable in society. In her research and practice, she develops and tests solutions to make healthcare more inclusive and more effective. She's also spearheading Our Care, a national initiative that is engaging the Canadian public on what the primary care system of tomorrow can and should look like. Okay, so thank you, Brian. We're gonna unshare the screen and kick right into our conversation. And I'm gonna begin by saying a few things about my understanding of some of the factors that have shaped where we're at with virtual care in Ontario today. So of course, prior to the pandemic, as we all know, a virtual interaction between a physician and a patient, or a provider and a patient, was not a publicly funded service. And so there were no billing codes in OHIP for virtual care. And therefore, although it occurred, I mean, we all have been, I think, calling our patients about their results, or to check in on them, or to follow up on something in a conversation by phone. Since the beginning of phones, this was not a formal service, and it was not one that had a billing code associated with it. And then, of course, with the advent of virtual technologies like Zoom and FaceTime and all of these other evolutions, this was not something, although patients were communicating with other professionals in their lives, in other sectors through these mechanisms, whether it's email, direct messaging, or a video call or a phone call. It seemed that the health system was kind of behind the times. And I think people experienced us as being behind the times. And I know that many of us who are clinicians have had the experience of patients feeling frustrated because they had to come in for something that they felt could have been dealt with through some more convenient mechanism for them. And perhaps that's why a market for private virtual care began to spring up in Canada in various different forms. But I would say it was a pretty small market for quite a long time. And so there were a few companies that were providing virtual services. And of course, because these were not covered by OHIP, we're sticking with the Ontario story for the purposes of this conversation. Because they were not covered by OHIP, it was perfectly legal for those companies to charge patients for those uninsured services. And so we would all hear stories of patients who were being charged $50 to have a conversation with an online doctor or an online team, and maybe someone would call in a prescription to their pharmacy or whatever it was. And effectively, I would say most of these models, although not all, and I know Bill's going to try to differentiate between different kinds of models for us and help us to understand how different models interact differently with the healthcare system. Most of them functionally have been what we would have thought of as a virtual walk-in clinic. In other words, an episodic interaction with a provider that the patient doesn't know. And because that service was not covered by OHIP, the patient was charged for it. And there were, of course, concerns about that from an equity perspective, from a continuity of care perspective. And yet, of course, one could not argue that in many instances, it might be convenient for a patient who had the $50 to have that interaction. Unclear, and not much research had been done about what the impact was, either on the person's health or on the health of the healthcare system. Fast forward to the pandemic. Sorry, people are making mention in the chat of telemedicine consults up north. And of course, yes, it's absolutely true that the Ontario Telemedicine Network was a leading innovation in virtual care globally for decades. Any of us who've worked in the north or in rural and remote communities would have had interactions with OTN. And although I will say that the original OTN technology perhaps was a bit on the clunky side, it was an extraordinary way for patients in rural and remote communities to access specialist care. and it was publicly funded, continues to be so. But that was a very particular model for patients in particular communities. And there were all kinds of requirements around where the consultation would take place, the necessity for another healthcare provider to be present, et cetera. So it was a different kind of model, not the model that we're going to be talking about this morning. That's more of a direct patient provider interaction without any sort of intermediary. But thank you for the comment. And so fast forward to the pandemic, of course, one of the most important things that occurred right away was the directive from the Chief Medical Officer of Health to only do things face-to-face that were absolutely critical in order to slow spread, preserve PPE, and focus on COVID care and allow for redeployment of staff and physicians into acute care. And that led to the explosion of these virtual care codes. And so suddenly these services were publicly funded. And that meant that all those physicians that hadn't been providing virtual care as a routine part of their practice, or for whom it had been a small sort of follow-up tool, were suddenly using it in some cases all day long. And it also meant that for many of these companies that had previously been functioning outside of OHIP, suddenly, and I will say through no fault of their own, they were offside the rules because you couldn't charge a patient anymore for a service that was now covered by OHIP. And so those companies faced a choice. The first option, of course, is to bill OHIP for the service, and that would be the sum total of what they earned for those interactions. The second is to bill OHIP for the service, but find other ways to bill the patient. And the question of whether this has put some publicly funded services effectively behind a paywall is one of the big controversies around the evolution of these models of care. I think we all acknowledge, first of all, that virtual care is here to stay. Secondly, that of course, a continuous relationship with a trusted family doctor or nurse practitioner or team, healthcare provider, and with continuity of care and virtual care as one tool in the toolbox is ideal. We also know that there are many parts of the province and country for whom that's not possible right now. And so this morning's conversation is about what are the better and worse ways to do this? What are the risks? What are the benefits? What should we be worried about and advocating for as academic family doctors? What is the evidence around this so that we can have an evidence-informed conversation? And with that, I'm going to open it up to my two colleagues who may share screen here and there to share a couple of slides to support one of their points. But mostly we're going to be having an informal dialogue here. And so I'll start with you, Bill, and then go to Tara and ask you just a wide open question. What do you see as the biggest opportunities and risks with respect to telemedicine and virtual care in Ontario today?
Well, thanks for that introduction, and nice to be here, and thanks everybody for joining. In terms of opportunities and risks, maybe if it's okay, I might just start with 2 slides, just to frame the conversation a tiny bit and get at a couple of points that you mentioned in your opening. So we talked about access to healthcare generally and virtual care. And so I just thought I would show a little bit of context. And I'm sure Tara will speak to some of this as well, because it's a commonly cited statistic that I think everybody kind of agrees on, which is that, we have almost 2 million people in the province that don't have a family doctor, and that number continues to go up over time. We know that people have been on waiting lists for 10 years plus. And in fact, there was an article that referenced that Healthcare Connect was referring patients to Rocket Doctor in order to see a physician. And that's because of the necessity of accessing care and because folks were able to get physicians, to get access. And so we did a data analysis where we took a look at postal codes of patients that were using physicians on Rocket Doctor. And I'll get to sort of why I frame it in that way, rather than say see Rocket Doctor, but rather physicians on Rocket Doctor. And interestingly, more than 50% were coming from rural northern communities across the province. And, you mentioned OTN. I actually went to Northern Ontario a few years ago with Bridge to Health. We were looking to partner with First Nations to provide healthcare services and saw some of the OTN stations in Lac Seul and Frenchman's Head. And they're great, fiber optic networks that were developed. But of course, now it's so much more convenient to be able to have folks access care in their own setting. And I think the key thing that's often missed as well is virtual care is convenient, yes, for folks that might be in urban centers that want to use it, but it's essential for people that live in rural northern communities that can't otherwise, and where there may not be physicians present. And so I just thought, you ask about access to it and what are some of the sort of challenges and barriers. Well, we did a prospective survey of patients on the platform, thousands of them actually. And interestingly, 50% of all the folks that responded indicated they didn't have a family doctor. So again, indicating the necessity of the care. And then much more interestingly, 36%, so that equated to about 50,000 patients before December 1st, indicated they were using physicians on the platform actually as their family doctor. And so I'm about to get it, and then I'll stop talking after one more slide, but basically the platform model is actually quite important of how this happens. And it's what enables specialty clinics like substance use services, where there's thousands of folks accessing care. And so my last sort of slide, and then I'll hand it over to Tara, is the idea that you mentioned corporations providing virtual care. The key differentiator for us is that we basically continue to function on the Canadian model, which is publicly funded healthcare. The difference is that we're a technology company like an EMR or like your stethoscope, where it's made by a company. We're a Canadian tech company that builds software that enables doctors to practice medicine. So we don't have a group billing number. We don't employ physicians. They come onto the platform. And what was really interesting to see, particularly in Ontario, is hundreds of doctors working together in integrated team-based models where you've got family physicians, emergency physicians, psychiatry, cardiology, substance use, physiotherapists, orthopods, collaborating together in a really cool integrated approach, able to work on the same EMR, share records, and provide that continuity care that folks were needing. So I'll stop there and turn it to Tara anyways.
Thanks, Bill. Yeah, so I think there's a lot that we agree on, Bill. I think we both agree that there's way too many people who don't have a family doctor, and that's like pretty one of the number 1 problems in this country right now. Our own latest data from our care survey that over 9,000 people across Canada found that 22% in Canada don't have a family doctor, and that translates to 6.5 million adults 18 and over. And actually, it's better, the situation in Ontario, believe it or not, than elsewhere. So Ontario had actually the highest portion of people reporting having a family doctor, but still it was far too many. So I think we totally agree on that. And I think we totally agree also that virtual care is here to stay and is a great tool that we should incorporate into the healthcare system. I think for me, where the area of discussion and debate is really about how we integrate it. And I worry that some of the ways that we started to integrate it during the pandemic were actually, kind of a Band-Aid solution to that very first problem, and a Band-Aid solution that I think grows the wound. And I'll explain a little bit more about that. So, when I think about the opportunities and challenges about something, Danielle, I think often about the 6 dimensions of quality. So we've got access, patient-centeredness, equity, safety, effectiveness, and efficiency. So maybe we could just walk through those a little bit right now. I mean, it's clear that virtual only walk-in clinics and virtual care integrated into primary care can provide really timely access to people. Whether or not it's patient-centered actually does depend on the implementation. So there was actually a time, as we remember, about a year and a half ago, where there were lots of news reports of people being frustrated that they couldn't get in to see their family doctor in person when they wanted to. And so to me, that spoke sometimes to a disconnect between, what the types of appointments we were offering and the types of appointments people wanted at that time. So patient-centeredness to me kind of goes to, what is it that people, what kind of appointments do people want? And of course, we need to steer them as well as medical professionals to say, well, actually, that's an appointment that might be best suited in person. And I think the most recent virtual care appropriateness guidelines that came out from Ontario Health, I see some people who are on that committee and driving that work on the call. They did talk about the importance of taking that patient-centered approach in directing virtual care. Then there's the dimension of equity, which is a really interesting one. So I think, Bill, you spoke really eloquently about how it can be a nice equalizer actually in rural communities to potentially get some access to care. We know that there are many people who are working numerous jobs, or maybe they have children at home or mobility issues. They can't afford to take time off work, or it's a lot to get somewhere, whether it's because of mobility or paying for parking, or the other barriers related to transportation. And so virtual care can actually be convenient for them, but also can be an enhancer of equity potentially. But it's also interesting that I think the flip side can be true too. So when we did a survey of, we've been doing a survey, I should say, of patients across all our 14 Department of Family and Community Medicine sites. Patient experience survey, we do it every 3 to 6 months since the start of the pandemic. And one of the things we found early on when we stratified our data by sociodemographic information, we found that people who were new to Canada, people who were living with a lower income, and people who actually had poorer health, they were all less likely to report being comfortable with virtual care options, and less likely to say that they wanted those options to continue. And interestingly, when we did a survey of physicians in the Toronto area, so over 1,000 physicians in the Toronto area in 2021, we asked them about what supports they would need for virtual care. And so, the top support actually was that they wanted email secure messaging, billing codes, and supports. But the second was that they wanted supports for their patients to be able to access virtual care and be able to navigate virtual care, which again, speaks to me that we have many colleagues who I think saw the struggles of some of our patients who weren't actually able to see us in the same way as others because virtual care actually was a barrier to them. So equity is a really interesting one. And then I think there's the dimensions of safety and effectiveness. And that's where it gets a bit tricky. So especially, I think this is where I think some of us have either experienced or seen anecdotally or worry about potential risks to patient safety because they are evaluated only on a virtual platform and not necessarily in person. I think some of that worry was there early in COVID when family doctors weren't necessarily seeing as many people in person, but I think that worry is certainly there with virtual only platforms. I think when it comes to effectiveness or whether people are getting evidence-based care, there's also a worry that, are we, for example, overprescribing antibiotics because we're not actually looking in the ear or not looking in the throat or examining someone. Then there's the dimension of efficiency. And so I think you can imagine that virtual care also, intuitively, we want to say technology is going to help make us more efficient. And I think we can all imagine scenarios where that's the case. But I also do want to remind folks that I think, there was a time where we had that virtual first approach. And so often, sometimes that meant that we were actually doing double the visits. We'd see someone virtually, and then they would have to come in person. And so there are, again, implementation issues related to efficiency. But mostly I've taken a perspective there now of the patient. And I wanted to take a little bit of a health system view too, because to me, there are a couple of health system lenses on those 6 dimensions that really speak to the opportunities and challenges. So the first is, the problem that we started with, which is not too many people don't have a family doctor. And what I worry about is with the growth of virtual only platforms and actually more just urgent care options in general, I worry about that this is actually making the problem of getting attachment to a family doctor who does longitudinal practice even worse. We see that there are many reasons why people are discouraged to go into longitudinal practice these days, continuity-based practice. People don't like the idea of starting their own small business, but it's hard when you're, basically always responsible for a practice, and it's hard to take vacation and parental leave. And so all of a sudden you have through COVID, the growth of urgent care options in general, but virtual only options as an employer for you. So you can join these and not have to worry about some of the things that I just talked about that make continuity-based care difficult and still get paid really well. And so what are these people who are working on virtual platforms not doing? Well, they're not necessarily going out there and starting out or working in a continuity-based practice. And so I do worry that virtual only platforms, as well as urgent care options more broadly, are actually taking away our human resources where they're needed most. And then I'll also come to the issue of health system use and cost, which I think I think, Bill, you and I have talked about on Twitter, because of course we published a study in January that showed that patients who attended one of 13 virtual only clinics that we were able to identify in the ICS data, they had 2 times the odds of going to emergency department after that virtual encounter than patients who were seen virtually by any other family doctor. And so just to clarify, it was any other family doctor, it wasn't their own family doctor. So yeah, there are limitations to the study we did for sure. And would love to talk about, what research we could do with you, Bill. But I think, when I've reflected on the results, it says a couple of things to me. One is I think, people often do need to be seen in person to be assessed for an acute problem. And so to me, it's fairly logical that many of them would require an in-person visit after a virtual encounter. And so it's not surprising to me that they would have more emergency department visits. And I think the second piece is, that when somebody's seeing someone at a virtual only platform that they don't know, the trust and relationship isn't there. And we've heard anecdotally, even on the radio, although there's been so much, discussion about this, just how, if people are seeing someone they don't know and they haven't been examined by them, they actually just trust the examination less. And that's another reason why I think they may go to the emerge. And I should put in the context that actually we also found that the people who used those virtual services, they were more likely to be healthier, so had fewer comorbidities and more and less previous health system use.
So that's
I'm getting the body language that I should probably stop talking. But anyway, I thank you, Danielle, for allowing us to give a little bit.
No, it's great. And I want to get into some back and forth because you said a lot of really interesting stuff there, Tara. Bill, do you want to respond to any particular aspect of what Tara's just shared, which is I like the use of the dimensions of quality analysis. I think it might be a helpful frame for the conversation. Go ahead, Bill.
Yeah, no, definitely. So I'm actually going to share a couple slides again, because I sort of obviously anticipated this to be part of the discussion. And I see we've had discussion about one of the research papers I'll cite and some of the context around it as well. But I think the interesting thing, the question here first, Tara, appreciate what you mentioned, but I think I just want to go back actually to this slide, which is that in terms of access to care, people who live predominantly in rural northern communities don't have doctors. And so I think it's a little wishful thinking to say we want them to come in person to a family physician. I was running the emergency department in Thessalon over the holidays, and patients were literally in tears because they couldn't get a family doctor because the one family doc in the community retired. And I feel like we've been sort of saying till we're blue in the face for many years that if we just throw more money at it, we'll recruit a doctor to live in those communities. And the answer, I think, is that's not the case, is that the typical physician doesn't want to be by themselves in a rural northern practice. And so I think we have to figure out ways to do it, but we have to use technology and be a little more innovative in our approaches. And so what that looks like and what has been incredible to see is that, physicians that live in, let's say, academic centers in downtown Toronto, London, Ottawa, they might have jobs as emergency physicians, they might have jobs as family doctors, they might work in urgent care clinics, and they certainly won't be able to fly to Northern Ontario for a week, to do a hospitalist locum or to run the emergency department or whatever else, but they can open up their computer and then they can do a couple hours, whether they're, in the call room of the hospital after a shift or wherever else, to basically provide services to patients across rural northern communities. And you mentioned that in your comments, the difficulty of having longitudinal care, and yet we know that they do have longitudinal care. And the reason why, and there were some comments on this as well, is that Rocket Doctor is not corporate medicine. We don't employ physicians, we don't hire them, they're not working for a group practice. Like I think every other company in Canada that functions in this way, every physician is an independent doctor, they have their own OHIP billing number, they have their own CMPA coverage, they're doing their own thing. We just help to coordinate that care with a back-end system, which enables a really innovative virtual family practice model where literally hundreds of doctors can work together. So you avoid physician burnout, you can provide care to patients. And again, this isn't, yes, some people do use the service who have stigmatizing conditions, like I mentioned, where we've got an integrated team-based approach for substance use. where thousands of people have helped to get off of alcohol, opiates, amphetamines, other controlled substances. But also for primary care, I've read notes from folks that say they live just outside of Ottawa. They waited 4 weeks. They couldn't get a refill for their prescription for antihypertensives. And I think when we're living in academic centers, it's easy to sort of forget how difficult it really is for the average person in Canada to access healthcare issues. And so this is just a study that we did with some of the physicians on the platform. And you'll notice that the vast majority do a varied series of practices, both in person and virtual. And, before December 1st, 130 hours a day of that added up to 500 patients per day, which is bigger than any emergency department in the province. So imagine that all shut down. And then when we look at data, we've got one of the authors, it sounds like, of the study from the virtual ER. I found this sort of interesting. There was one of the critiques of the study at the end in the conclusions, which was that, predominantly patients had family physicians. It'd be great to have a virtual provincial urgent care clinic where folks without family doctors could access the service. And I would argue that was Rocket Doctor. And, again, when we look at our own data for what happens from a quality perspective of patients, again, thousands of patients prospectively surveyed after their virtual care visit, what happened to you when you were done? And 75% resolved by a physician on the platform. And very few of them, you'll notice, went to the emergency department. And then as we kind of look through further and we asked them, a couple of other questions, what would you have done had Rocket Doctor not been available? 50% said they'd have gone to a walk-in clinic in person, 33% to the emergency department. So I think while your study is certainly interesting, and retrospective analysis gives us correlation, but not causation. And it also doesn't have a control group that looks at in-person walk-in clinics and what would have happened otherwise. And of course, there's confounding because it was at the start of the pandemic where folks were sick, needed in-person swabs, and virtual care was new and people were getting adjusted to it. So what I'd love to see, and I'd be glad to collaborate, as you say, but I think a prospective cohort study would be really interesting, and actually looking at what happens to distinct populations over time who have differential access to care. And I will say there's been a lot of really interesting literature lately on virtual care services generally for substance use, family practice, that actually show the opposite, that it's quite safe and effective when done virtually. And our data supports that as well. So maybe
Can I come in a little bit on some of these HR issues, because I think you're both raising really important, and in some of the Q&A that we're seeing coming up in the Q&A, there's reference to, is some of this gendered for women coming into family medicine who are raising young families? Are some of the considerations ableist around physicians who have disabilities or, in the COVID era have felt more vulnerable. And so, on the one hand, I think the argument gets made that it's better for physicians who have any number of different personal factors to be able to interact with patients through a virtual platform, and that allows them to provide a service that otherwise they might not be provided at all in the system. On the other hand, as you've said, Tara, the concern that it draws physicians away from comprehensive care at a time when what we want is to be enticing physicians to take on a practice, because no matter what, I think we're all in agreement that it would be way better if everybody had an ongoing relationship with a family doctor. So how do you think about the human resources aspects of this, Bill?
I mean, from a HR perspective, I think there's two ways to look at it. The first is that it's a very slippery slope when you start to tell doctors what they can and cannot do to practice medicine. We've trained for more than a decade to have a set of skills that are in high demand around the world. As Canadian physicians, we're some of, I think, the most competent on the planet. And so if you start to tell a doctor, you're a bad doctor, you should do this in your in-person care, I'm going to tell you what you're allowed to do. I just think we sort of set a bad precedent. But then, taking all that aside, looking at it tangibly, yes, there are some circumstances where physicians will say, I would like to do full-time virtual care. And I think we should ask ourselves, is that appropriate? Do we want to have some sort of set of definitions? But when you let folks who are ethical and professional and have gone through clinical training make their own decisions, they often make good ones. And so, we're a self-regulated college and a profession. And what we see is exactly that on the platform, where the vast majority are doing a wide variety of clinical practices, and they're using this as a way to add something to their clinical duties. Like, I would question most of the physicians on this panel, how many of you only have had in your career a single job? versus you might work at a couple different facilities or a couple different academic centers or a couple different hospitals. And, there's no different of docs that choose to use our technology to see patients virtually. And so we just basically enable them to have more choice. And then if you've got a doctor that wants to do more work, wants to see more patients in the midst of a healthcare crisis, why would we tell them, bad doctor, you shouldn't do that? You should go work at an in-person clinic. Then they're just going to say, well, I'll just take the weekend off, forget it.
Tara, do you want to respond to that or to any of the data that Bill just put up on the screen?
Yeah, I wanted to respond to a few things. So first, I appreciate your critique of our study, and I would invite you, Bill, actually to make your own data public, because we have put forth peer-reviewed research that I agree has limitations that we ourselves have written. And I think you've talked about how you've published in the New England Lancet, so I know you've got the academic cred, and so it would be wonderful to actually have your data public so that we could all see it. I think the other thing I want to talk about it. So I want to talk about a few things. I'm very deeply aware of the problems we have with access to primary care. I'm leading a 15-month-long initiative to engage the public about what the future of primary care should be, and I want to get back to that actually soon. And recently was on a call-in show, Ontario Today, where we heard directly from so many people who didn't have a family doctor and were doing awful things, things that they shouldn't have to do to get care. But I also have been lucky to meet some really great physician innovators like Jonathan Fitzsimmons, and I recognize the issues are different in rural areas. And I think Jonathan's model offers actually a way for us to have the best of all worlds. So he works in Renfrew County. It's a really large geographic area that is very underserviced. They haven't been able to even hire into their faux spots for years. And they had started during the pandemic, this integrated virtual triage and assessment kind of program together with paramedics. And they've morphed that now into integrated virtual care. And by integrated virtual care, what they do is that they have family doctors who sometimes are virtual, but they also have actually a whole team of people, including paramedics, nurses, and nurse practitioners, who are able to provide the continuity-based care and the in-person care, even if the physician is not there. And the person is actually attached to the practice. It's not that you're just providing temporary care. And so when we're looking at models about servicing rural areas, I would love for us to think about how we can integrate continuity-based models. I also want to go back to the HR issue a little bit. We've done some work looking at comparator OECD countries that have very high attachment rates. And one of the things that struck me in this work, so we look at places like the Netherlands or Norway or Finland or Denmark. These are places where most people have a family doctor. And actually, there are next to no walk-in clinics. That's just not a thing. And it's partly because all of their physician workforce, family physician workforce, is providing longitudinal continuity-based care. And I often wonder, what if we, repurposed all of those human resources to provide longitudinal continuity-based care? How can we make that happen? Well, yeah, that's a bigger question. We can talk about that. But I do think we have an HR shortage, and I think many of us know intuitively that ourselves, our colleagues, we often work to an income target. There's only so many hours in a day that we're going to work. And this is a bit of an empiric question here too, like what has been the impact of doctors working on virtual platforms on in-person care? I think people have anecdotes either way. So yeah, let's do a study to try and sort that out. But the other thing that I want to bring out here is, when this pandemic started, there was a public option of a virtual platform that unfortunately wasn't successful, and I don't know all the reasons why. I think it was called the Ontario Virtual Care Clinic or something like that. But what makes that different from things like Rocket Doctor, I believe, and Maple and others, is that it's, Maple as an example, and I'm guessing Rocket Doctor as well, Bill, although I'm not an expert here. Many of the virtual only platforms are, investor-owned, shareholder-driven type of companies. So yours might be an exception, but many of them are. And so there is a profit motive there, and we haven't started to talk about how that shapes then the care that we deliver, but also the risks that that poses to patients potentially around, for example, things like use of their data without them knowing about it, advertising to physicians from pharmaceutical companies covertly that might actually change the way that the physicians behave. Those are things that are real and we know are happening. I do want to go back to this survey that we did of
well, maybe actually, sorry, can I just
go ahead.
Because I think it's actually a really important point that you raise. And so here's an example. I started and lead a nonprofit, Bridge to Health. We work with governments to help build comprehensive healthcare in rural underserved communities around the planet, mostly in sub-Saharan East Africa, have a Grand Challenges grant in Yemen. When we take a team of volunteers to work with the Kisumu County government in Kenya, they fly on Ethiopian Airlines in an airplane. They use stethoscopes that were purchased from a private company. We use technology for the dentists with tools and instruments that were built by dentist, other companies. Similarly, as a family physician, you use an electronic medical record. You use various tools and devices that were produced by companies in order to advance the field of medicine. And so I want to make a very clear line of sight and distinction in the fact, again, just to say it again, Rocket Doctor does not employ physicians. It's not a corporate practice of medicine. And I believe we are the only company in Canada that does not employ physicians or have a group practice in that model. And so I really want to make a clear distinction between that, which is we don't tell doctors how to practice medicine. We don't tell them what to do. Doctors tell us how they want to practice medicine. We enable them with digital tools to do so. And then we create a single brand in order for patients to have confidence that they can come in onto the platform and see a physician. And what we've built that's extremely important and innovative is the ability for hundreds of doctors to work together in an integrated team-based approach as independent physicians, actually, that can collaborate so you don't get physician burnout. You can provide access to care. We're a technology company. And, to Alan's question, we make one day, we've actually, interestingly, we've invested an enormous amount of money to build technology and to create a system of care. And I think one of the funniest sort of anecdotes here is, we've raised external capital from private industry in order to fund public healthcare for Canadians, for 250,000 Canadians. So this is actually the biggest coup for the Canadian system. We've employed Canadians. We provided free, publicly funded healthcare services. We've enabled doctors to do it. And yet we're being lumped into a category of evil private medicine. I just think it's an incorrect assumption. And so I'm glad
in hot pursuit on that, because I think what you're saying is fair, Bill, and like that there are differences between models, but maybe I'll put you on the spot and say, do you what's your view on Maple and its equivalence? I'm not trying to single out Maple per se, so I'll take it back. What's your view on companies that are not platforms and simply technology tools, but that do in fact employ physicians and advertise virtual only services to patients? And is your distinction sufficient enough that you would actually say you think the Rocket Doctor model supports patient care and public health care, and that you would not endorse these other models?
So I'll just preface by saying I worked with Brett in the emergency department at Centenary, and
this is not about Brett, but look,
I actually, as full disclosure, I actually worked with Maple at the start of the company. So back in 2015-16, I was doing my public health degree at Hopkins, and I got a reach out saying, "Hey, can you help us?" And I'd been interested in, technology from actually working in East Africa, where you're trying to figure out how do you bring healthcare to villages that lack running water and electricity, let alone a doctor that will live there. And there's lots of similar parallels. And to Tara, your point before, I was on the Lancet Commission for Diagnostics as a commissioner, looking at access to care and education training in rural areas. NOSM is a great example of getting physicians to work in rural northern communities by training them there. But anyways, I started to work with Maple, thought it was really interesting, didn't like the idea necessarily of having to charge Canadians privately for healthcare services. And so flipped more into a M&E role, and then went back into the, nonprofit Bridge to Health academic medicine space. But with Rocket Doctor, our focus has been on publicly funded healthcare services, companies. We flipped on a private chat service after the physician services agreement on December 1st. You'll notice that it is not available in British Columbia or Alberta. And the reason for that is because those provinces have, at least till this point, kept full funding for virtual care for their population. And so in Ontario, I'd love to be able to turn that service off if we were able to come up with a more creative way around reimbursement for physicians that said, if a patient, for example, has no family doctor, let's make sure the physician providing them care is fully funded. If the patient has a high acuity issue, so I'm an emerge doc at midnight in the department, every shift, I'll see patients who come in with acute pain that probably didn't need the ER, but they're scared and they don't know where to go. And we're always open 24/7. So they come to us. A doctor that sees that patient, we have 2 virtual ER partnerships we just announced with Brant Community Healthcare Center. If a doctor helps a patient who's already in the ER thinking about going to ER, avoid an ER visit, that doctor, A, should be paid at full reimbursement, and B, should not penalize the patient's family physician with a negation code, because that family doctor can't be expected to be available at midnight every night on, with one hour for an acute issue. So I think we just have to think about how to build the public funding in a more appropriate and nuanced way to support various models of care.
Okay, so are you against models that charge patients?
I would prefer for public funding to appropriately provide the level of service, and I'd love to do that. And again, yeah, it's not in BC and Alberta for us because there's full funding on the public infrastructure.
Okay, that's fair. Thank you for letting me pursue you on that. Tara, did you want to respond? I know you said you wanted to show some data. Is this a good time to do that?
Yeah, I mean, I think I also wanted to just pick up on Bill's points around the virtual ED work he was talking about, and just acknowledge Shelley McLeod on the call, who helped lead a study related to evaluating virtual EDs. And I mean, I think the conclusion in their study, the overall conclusion was that actually the virtual ED model overwhelmingly provided care to low acuity patients with a low risk of subsequent ED visit or hospitalizations. And yeah, patients liked it, but given that it was a low system priority at a time of severe HHR shortages. So I think, lots of interesting perspectives. And to your point, Bill, I think their study actually was prospective. Shelley put that into the chat. And so love to have Shelley.
I didn't say Shelley's study wasn't prospective. I was referring.
No, I know you were talking to me, but I'm saying that there has been prospective work. That's my point. So that Shelley's was a prospective study. So, I think I just wanted to talk about, yes, we're providing a service, but we have limited resources. And, how can I'm always thinking about how can we use the resources to serve those who need it most? Yes, we need to serve those who don't have a family doctor. And in particular, those who are racialized, new immigrants, people who are low income. That's, I think, where we need to ensure people are getting the service, especially those, who are older, who have multiple medical problems. And I think it's still a debate here, Bill. Both Shelley and our study found that those virtual clinics actually were serving more likely to be and that younger, not children, but like young adult, like 30 to 49 kind of age, healthier people. So that's just one point I wanted to make. I think the second point I wanted to make, Danielle, was just about what it is that people want. So we've been doing this work called the Our Care Initiative, where we started off with, it's a 15-month long initiative to engage the public about the future of primary care. The first stage was a survey we did nationally. Over 9,000 people in Canada responded. Lots of different stakeholders provided input into the survey, and I'm going to show you some of the results. The second stage is actually a dialogue with patients. And so we brought 36 randomly selected people who volunteers. I've never met them before. They never met each other. They're here in Toronto, and they're actually discussing, learning about family medicine for about 40 hours and deliberating about the future. And interestingly, Bill, we actually have Brett Belches coming to talk to them this evening together with Cheryl Spithoff. So it should be a really interesting discussion. But all this to say is that, I'm open to these discussions, but I want to share with you some of this data. So we, of course, confirmed many people don't have a family doctor. We also asked, where is it that you might have gotten care if you didn't have a family doctor? And absolutely, people were saying virtual walk-in clinics were one of the places. So I want to acknowledge that this is one of the things that people were doing. But interestingly, we asked this question of, in some parts of Canada, There are new virtual services where you can quickly and easily connect with a doctor by phone, video, or online chat at a day or time that's convenient to you. However, these new services, you may not know the doctor may not have access to your health records, and the doctor may not be able to schedule a follow-up appointment in person. So how willing would you be to use these services if? And it was really interesting to me, some of those most interesting findings really, that 58% were not at all or not very willing to use a service. The service was owned by a for-profit company. 70% were not at all or not willing to use it if the company that ran the service received payments from or was owned by a pharmaceutical company. Maybe I'll jump to the last one here. 84% were not at all or not very willing to use these services as a company that ran the service sold their health data to pharmaceutical or insurance companies after removing information that could identify them. So people are using these services, yet they actually are an antithesis to what it is that they desire and that they value and that they want. And part of this is that we're not putting the options that they want on the table for them. But part of it, I also think, is that they're not probably being informed of how their data is being used. And all of the things in these questions are actually things that do happen with virtually only platforms. We did ask them in a separate question, when you think what's important about getting care from a family doctor or NP or practice, how important are each of the following to you? And interesting, like the top response of what was very important to people was that they know me as a person and consider all the factors that affect my health. The second was that they stand up for me. And the third was that they coordinate the care I get from multiple places. Only then does access chime in to making sure they have urgent access. So to me, this actually really speaks to the importance for people when they're designing a system, what they value and want. They want the relationship. They want someone who knows them, who cares for them, and who's able to take their specific needs into account. And I would put forward that I think in order to do that well, what we need to do is get everybody a family doctor or NP in a model or team where that can happen. And virtual only platforms, I worry, are taking away the HR resources that allow us to do that. And at the same time are a Band-Aid that are actually not in line with people's values and priorities.
Thanks, Tara. So I see there's a hot debate happening in the chat, which is great. This is exactly what we want. And there's some good questions in the Q&A that I'll invite our panelists to try. I know it's hard to both speak and type, but answer where you can. For example, Bill, there's a couple of questions about the profit model of Rocket Doctor and how does Rocket Doctor make a profit if it's only billing the public system. And I do think that there are some yeah, I'm just looking through. So I've been trying to integrate some of these questions as we've been going along into the conversation. There's also been some discussion about data, quite a few questions about data. And I see that you answered some in the written Q&A, Bill, but maybe we could talk a little bit about data because that's something we care about as an academic department of family medicine. We want, of course, population level full coverage data for every interaction that Ontarians have in primary care through electronic medical records. We want to grow the Utopian Poplar network so that we can have a good line of sight. And we want to, of course, be able to compare models of care, their effectiveness, their patient-centeredness, questions like who goes to the emerge and why and when and after what kinds of visits. All of these things really matter. And Tara, there are some requests, by the way, in the Q&A for links to some of your papers, and maybe you could put those in as well as the Our Care link for people who are interested. So Bill, do you want to say a little bit about data? And of course, we worry a lot about having to interact with private sector vendors of all kinds in trying to get access to data because it's not always easy to do for quality improvement and research purposes. And not specifically about Rocket Doctor, but you can say about Rocket Doctor if you want, but like, what do you see as the considerations related to data as we see a proliferation of more virtual care clinics?
Yeah, I mean, Danielle, I guess because I reached out to you like a year and a half ago about how I wanted to try to integrate data streams with Rocket Doctor, was my background in public health. I think what's interesting from the map that I showed of the postal code analysis, we've looked at it in British Columbia and Alberta as well, where Rocket Doctor is live and the statistics are the same in each province, which is majority of patients using services. Physicians on the platform come from rural underserved communities. And I actually reached out. We were told we were the first company to ask Connecting Ontario to integrate, but it's great that we have provincial systems, but the wheel turns slowly. So it's been 2 years and we still haven't received a technical integration document from the provincial system, and we'd love to integrate with them. From just to Tara's point, we don't sell data to pharmacies, and so that's not what Rocket Doctor does. So that may be relevant to other companies, but certainly not folks that use our platform. We have privacy policies, certainly on the website, that outline terms of use, and that your data in an anonymized fashion might be used for research purposes or analytic purposes, which is what I've just showed today with some of those graphs and statistics. I also have a keen interest in data science and predictive analytics. So that's part of what my interest is on, can we, I think what's been often lost as well is that the line I used to love saying is that it took a global pandemic to pull medicine kicking and screaming out of the dark ages into the 21st century. How could we have ever gotten adoption of physicians to use technology from less than 1% in Canada to like 50% overnight? And we've done this where we talk to each other on a video in order to basically survive because we couldn't see our patients in person. Of course, we were like in the emergency department when we were there at the start of the pandemic. And so had to sort of find a way. But in general, for many folks, and then that's now created all of these other opportunities that I think we have to catch up to and basically figure out how do we integrate that in. In Alberta, they have Netcare, which is the provincial system. Interestingly, it's run on Epic, on an American company. I don't know why it couldn't be run on a Canadian company, but the idea that we're working with the Alberta government is, could we provide and build some sort of integration of that service where it can all be interconnected? I think there's lots of opportunity to sort of think about things in a more innovative way, basically, and do data sharing to your initial question and how that can, build the system.
Thank you. So as we careen towards 9 o'clock, I just want to wrap this up by saying I think you were both really brave to do this morning, and you've both been terrific about clearly pointing out the areas where you disagree, and also being collegial and respectful in the way that you're communicating with each other. And that's exactly what we had hoped for this morning. What is the purpose of a university if not to support and encourage hot debate on issues that really matter to people? So thank you both for doing this, and we're going to continue to explore new ways of interacting in these rounds in this speakers series. And so I want to thank both of our presenters. Thank you. And put in a plug for our next session in late March. Dr. Kwame McKenzie, the CEO of the Wellesley Institute, will be doing a session related to the social determinants of health, possibly with another surprise guest. And so thank you all for joining this morning and for participating in this really important conversation. I can't think of a more topical way to kick off a Friday. Have a great day, everybody.
Thanks.
Thanks, Danielle.
Thank you.
Thanks, Bill.
Yep. Thanks, Tara. Bye, everyone.